Good morning, everyone. It's nice to see you and nice to see those of you online, wherever that might be. So it's my privilege to introduce Rachel Vogel today. Rachel is a associate professor in the Division of Gynecologic Oncology. She did a master's degree here in biostats under Jim Neaton, and then worked in the biostats course. So many of you may know her from her expertise there. She is still a very highly sought after biostats colleague. In 2016, she finished her PhD in epidemiology, again here at the University of Minnesota, under Deanne Lazovich. And Rachel was really an important piece of the skin health study, which looked at indoor tanning and melanoma. And that study was really an important study for establishing laws across the country around indoor tanning. And as part of her PhD, she really took the initiative to work on survivorship within the construct of that study and has done amazing work in melanoma survivors, which she's not going to talk about today. You'll have to go online and look at one of the prior seminars, which I'm sure there's one recorded anyway. So she has historically been our melanoma person, and survivorship is the thing she's very passionate about. Another really important thing that's going on for Rachel is she has a new R01 with Julian Wolfson to look at time toxicity, a new concept that lots of people here at the university are working on in cancer survivors. And it's a really innovative study, and I look forward to hearing about that in the future.
I'm not talking about that either.
Nope, that's the new, I'm letting everyone know how awesome you are. So in 2016, she finished her PhD and she went right into a faculty position, which should let you also know what a superstar she is and how methodologically and scientifically sound she is. So today she's going to talk about new stuff that's maybe even a little outside her comfort zone on cytomegalovirus and ovarian cancer outcomes. She's been funded by the DoD to do this work and just received additional funding from the DoD and MOCA to continue working on CMV reactivation in ovarian cancer. So thank you, Rachel.
Okay. Yeah, thank you, Heather. And so just for all of you who are maybe postdocs or new faculty, this is what happens when you put multiple eggs in the basket right away and you try to figure out what's going to take. Yeah, there are lots of different things going on, but they really do all fall under this umbrella of cancer survivorship. And so that's what I'll first talk to you about. My assumption is that many of you are basic scientists. And so just to kind of give you a peek into my world of cancer survivorship, and then I'll tell you a little bit about CMV and ovarian cancer, which is what I'll be specifically focusing on today. And then the work really spearheaded, I would say, by Heather, looking at CMV and cancer and what, where can we go with that? And so that is the data I'll be sharing with you today. I will be really clear that most of this is preliminary data, either very recently published or not published at all. And my favorite kind of science, because every time we think we're answering a simple question, we actually just come up with 10, 20, 30 more questions. So just know that that's the state that we're in, right? So I hope that you ask us those questions, but very likely I will say, great question, I don't know the answer. And so but if hopefully something here sparks some interest in all of you as well. So, I'm a cancer epidemiologist who focuses on survivorship. Many of the questions that we have are more basic science, are molecular epi, these things that are not my expertise, but I think are really important questions to answer so that we can do the work that I'm really interested in, which is making life better for people with cancer. So I think many of it, everybody in this room is aware that cancer, not only is cancer incidence increasing, but survivorship is increasing. We've made really huge strides in cancer treatment over the last couple of decades. And so we have more survivors. So we have an aging population who's getting cancer, and we have people living longer with cancer or past cancer because of the treatments that we have. And so that really means that in the next decade, we're going to have over 26 million cancer survivors in the United States. And you can see the age distribution here, a growing, aging population, but there's plenty of young cancer survivors as well. And so the NCI defines a cancer survivor as anybody from the time of diagnosis to the end of life. And so that's when I talk about a cancer survivor, that includes somebody who was diagnosed with cancer yesterday. That includes somebody who's living with metastatic disease for the last 10 years. That includes somebody that was diagnosed as a 5-year-old and is cancer-free now at 30. Okay, all that, cancer survivor is a very broad term. And I think the most important thing really in the survivorship space is to understand that treatment is not without cost, right? So we have some really strong drugs and surgeries and radiation and all of these things do a good job at getting rid of the cancer, but they also do a lot of damage in the process. And a lot of that can have really significant long-term effects. And so that is really where my focus is. And it's really only in the last, since 2005-ish, which for as old as I am, that doesn't seem that long ago, but now, almost 20 years ago, but it's really since about the early 2000s that we actually systematically look and think about survivorship. Before, everything was about, we just have to cure this. And like I said, we've done a good job of moving in that direction, but now we need to focus on these survivors. So in 2005, the Institute of Medicine report, this is, anybody who does cancer survivorship kind of knows about this report, but really was the first time that it was called out like, hey, we got to focus on cancer survivors. They're experiencing physical, emotional, social, behavioral issues that we're not addressing. And so that's really, again, where my passion lies. And so this is probably way too tiny to see. But really, cancer survivors deal with a whole wide range of concerns. And that is partially why it seems like my work is kind of all over, because cancer survivors are dealing with a lot of different things. And so today specifically, I'm going to focus on those 3 highlighted, and actually peripheral neuropathy, I'm not really going to show that data, but fatigue and cognitive impairment are 2 kind of physical concerns that a lot of people face after a cancer diagnosis and treatment. And so in this space, so this is the world that I work in. So about 5, 6, 7 years ago, some amount of time ago, Heather sent me this paper. And so those of you who don't know, Heather's a molecular epidemiologist, now focuses a lot on environment, but really, I would argue her passion is viruses and cancer. And so she was really interested in CMV, and she sent me this paper. And she said, Rachel, what do you know about measuring fatigue? What do you know about fatigue and cancer survivors? And I was like, I know fatigue is a big issue and I know how to measure it. So let's put in a grant. And so that was really kind of the start of, Heather's the expert in the viruses, I'm the expert in survivorship. Where can we overlap? And so this paper showed a few years ago an association between CMV status using IgG and fatigue. So people who were CMV IgG positive at diagnosis had fatigue, were more likely to have fatigue following treatment. And this was shown in breast cancer. And so we're like, okay, let's look at this ourselves. So CMV, again, this is, Heather knows a lot more than I do, but so CMV is a herpes virus. Most of us have been exposed to it. Most of us have had it and didn't even know it. By age 40 or 50, about half of the population has been exposed to CMV. It's typically asymptomatic. It can, if you are immune suppressed though, so it's severe immune suppression, HIV, AIDS, BMT, it can have really devastating effects, but most of us would have not even known we had it. And I always say it's similar to chickenpox and shingles in that you can have that exposure and then later in life, during a stress event, during immune suppression, it can come back, it can reactivate, much like shingles can come back later in life. And so there's a few studies prior to the work that we had done showing that CMV will reactivate or can reactivate with chemotherapy. And so again, I would say this is work led by Heather to really kind of create this whole program around what is CMV doing in cancer. And so she is thinking all the way from the risk side through survivorship. And all of these questions that we have about how does it reactivate? How does it reactivate? What does that mean for long-term outcomes? What does that mean for treatment alterations? There's all these questions that we can ask. And today I'm going to just provide you some, again, mostly preliminary data on some of the work that we've been doing here, focusing more on that treatment and survivorship phase. And so these were our original questions. Like I said, I don't even have the answers to all of these, and I have about 50 more since we've started this work. But we wanted to ask, how often does it reactivate during chemotherapy, and for which patients, and when does it happen? Does it happen right away after cycle 1, or is it after cycle 6? Does it increase your side effects? Does it impact your treatment adherence? So you get sicker, so then you have to delay, you have to take a longer break between cycles 2 and 3, for example. What I'm particularly interested in, does it really increase your fatigue or other patient-reported outcomes? Does it impact survival? And then, importantly, could we mitigate all of this with viral therapy? Okay, so those are the questions that we kind of started out with, our big questions. These ones in orange are the ones I'll show you some data on. Not to say that we aren't still interested in all of these, but each one of these takes a tremendous amount of data to try to better understand. And so the tools we have for investigating this, we have IgG, which is what most people have used in the research to date, which is just essentially saying, have you been exposed to ZMV in the past? Do you have antibodies? And that's what's been used again in the research to date. And then now we have a newer tool that I would say clinically has been used, but not been used in research, measuring the cell-free DNA. So really giving us an understanding of what is your active viral infection, your viral load right now. And so that is what we have been using in our studies to better understand kind of what are people experiencing right now as opposed to their history. So ovarian cancer, just to give you a little space. So we have all these questions. I'm in the division of gynonc. I should probably focus on a gynonc cancer, right? So and I've done quite a bit of work with Melissa Geller and others, and we have a strong ovarian cancer program here. And so I'll tell you just a little bit about ovarian cancer and all the work that I will be presenting today. All of that data was collected in among ovarian cancer patients. So ovarian cancer, when we say that, we actually just mean a group of diseases that all originate either the ovaries, the fallopian tubes, or primary peritoneal cancer. And I will refer to that as ovarian cancer throughout, but I mean all of those cancers, primarily because they're treated exactly the same, not because we think that they're the same, but that's just the best that we can do right now. And the median age of diagnosis is 63, and I can't do a talk, you can't be an epidemiologist and not do a talk that shows this figure, because we always show it. But so actually ovarian cancer is number 11, so it doesn't make the list of new cases in women. It's number 11, but it's actually the number 5 in terms of death. So it is, while it is pretty rare, it does contribute a lot to death of women from cancer. And that's primarily because there's no good screening. So we don't catch this disease until it's advanced. So about 75% of cases are diagnosed at stage 3 or 4. And you can see in this figure that there's a huge difference in your survival. If you're lucky enough to catch it at stage 1, your 5-year survival is almost 90%. But again, most people, it's stage 3 or 4, so 5-year survival is more around 30%. The primary treatment is chemotherapy and surgery. I would say that's the timing of that is evolving. It used to be almost always primary debulking followed by surgery. Now it's about half and half, neoadjuvant chemotherapy followed by surgery, followed by more chemotherapy. There's also a lot of maintenance. So for some people, depending on your BRCA status and other mutations, you might have PARP maintenance, you might have bevacizumab maintenance. And this space is slowly evolving, but we haven't really made any big progress. And unfortunately, once you recur, which is 75 to 80% of people, once you recur, it's considered a chronic disease, and you are, really going to be continually on treatment, essentially, after that point. And so it can be a really devastating disease. And so, like I said, we here have a lot of people focusing on this work. So we actually have quite a few data sources generated both by myself, Dr. Geller, Dr. Nelson. And so these are the data that, except for the bottom two, I will be showing you some preliminary data from. The data sources here are primarily Fairview, with a more recent from MNCCTN. So anybody who's worked with them. They're able to get us patients from rural Minnesota from some of our other outlying clinics. And what we really need for this work is, blood to analyze the CMV status. And what's harder to find is the patient-reported outcomes, the surveys. So that is where I have had to do, that's my expertise. That's where I come in. But that's also why we've had to generate our own data sets. It's very rare to find a data set that has both. I can find surveys, I can find blood, but finding them on the same people has been historically difficult. And so that's why we have these prospective studies that we have done. So for our first question, what proportion of people newly diagnosed with ovarian cancer are CMV positive? And then is that associated with survival? And so part of the thing that, part of the story, only part, which you'll see later, part of the story, I think part of what we think is going on here is inflammation, right? So we think that the virus, we know that CMV infection is inflammatory. We know that this activity creates that inflammation. And we also know that CMV has been associated with increased mortality, irrespective of cancer, but just that in itself has been associated with increased mortality, okay? And we know that there's this link between the two. So if you can see here, being CMV positive and high inflammation is the worst scenario. So that in this survival plot, that's that lowest group, right? They are the ones that have both inflammation and CMV activity. And so that matters, that inflammation status is we see that in these big data sets, and then we actually saw it ourselves in our own data. So this is data from Melissa Geller and Amy Skubitz, and 106, and these are actually all high-grade serous ovarian cancer, so a pretty clean group. The rest of them are not this clean, but a clean group of people, and 60% of them at diagnosis, these are blood samples from diagnosis, looking at their overall survival, 60% of them were IgG positive at diagnosis, which is what we would expect, slightly older group. Most people have been exposed. And we found that the bottom group, the blue line there, that is people who are CMV IgG positive, so not active infection, but history of infection, and high CRP, so high inflammation. They had the poorest overall survival, and pretty dramatically different. I think one piece here we don't know what to do with is that red line, which is actually maybe the best. You get there's some overlapping there in terms of the Kaplan-Meier curves, but that group is CMV positive, CRP negative. So, what does that mean? Is a little viral activity actually maybe good? Maybe, I don't know. So this is kind of the first time that we really started thinking that it's, all these times when we think we're asking simple questions, they're not simple, right? So here, there's probably some immune system pieces going on too, right? So we're kind of adding to the story. Again, interesting data, now what, right? And again, this is IgG. So most of the work I'm going to be showing you from now on, we're switching to this active viral load because I really think that that's actually what we're really interested in. So two different cohorts. We looked at active CMV at the time of diagnosis. And you can see that about a third of the patients with ovarian cancer had active CMV infection at diagnosis. And all of this is primarily subclinical, right? So they're not showing outward signs of infection, but that's pretty high, right? And so now that we know that, now we want to see, okay, so we know that some proportion have these active infection, and that's a diagnosis. What happens during chemotherapy? We're taught that's that difference between, having it at diagnosis versus reactivation, right? So the chemotherapy pushing somebody potentially into having this active infection. And so this is actually some work even older than 2005, 1981. Some of this work had been and shown even back then, showing that these were, this is old. So breast cancer, 5-FU and methotrexate, drugs we don't use in this space anymore. But they were, of those people, it's a small group, nine of them were IgG positive. And then you can see over time is that very top graph that 6 of the 9 of them had a significant rise in their CMV activity after starting chemotherapy. So for them, we would think that this is potentially reactivation going on. And interestingly, and we've seen this too, herpes simplex is the second one there. We've looked at EBV, it's not quite the same, right? So there seems to be something about CMV. And so I think that's just, again, this is preliminary data that we've now, or, data before us that we have generated some additional preliminary data. It's like every time we look at this, I just have more questions. And so this is data from internally here. This is only 18 people. Those of you who do this work, it's actually very, very difficult to get serial blood samples, at least here at the CC. Anyway, so we're looking at here, it's the proportion of people who are DNA, CMV positive at diagnosis in this group is about 25%. And then it goes up to almost 60% after 3 cycles of chemotherapy. And then it, coming back down. And what's interesting here, so out of these 18 people, 16 of them were CMV positive at some point between diagnosis and 6 months of follow-up. So almost everybody experienced this activation or active infection during treatment. And then Heather drilled down a little bit further and looked by cycle. And you see the same here, again, very small sample size. But you see here, again, this one is not as obvious as some of the prior work. There's some other work that has shown almost everybody reactivated in cycles 2 and 3. That's not quite what we see here, but you still see this, there's quite a few people experiencing active infection kind of throughout treatment. And so one thing that we are learning in retrospect that, we also would, in an ideal world, have collected urine or saliva or other ways to confirm that this is, active infection that we can see from multiple sources. So regardless, I think, we feel pretty confident that something is happening during, that CMV active infection is happening. And this is something we need to further understand. And so then you get to the questions that I'm really interested in, right? So, okay, this is happening, but so what, right? So, and we showed originally, potentially a relationship with survival. And again, I'm really interested in these patient-reported symptoms. So in the case of ovarian cancer, these are the top concerns that patients report. Fear of recurrence, which certainly makes sense. Fatigue, bowel disturbances, a lot of that, related to the location of the disease. Neuropathy. And then one thing I'm going to talk quite a bit about in addition to fatigue is cancer-related cognitive impairment, often termed chemobrain. It's not just related to chemotherapy, but that's a lot of times when patients talk about it. And then emotional distress. And so I'm going to, these are the things that are most commonly reported by ovarian cancer patients and really can be quite, have a significant effect on their lives. So, certainly if you are younger and trying to still work and you are having trouble remembering things or where you put things, that makes a huge difference. But even so my grandmother had ovarian cancer. She was 75 and really smart woman, retired, but she was real mad. She couldn't do her crossword puzzles every day, right? So, these things that this affects patients' lives kind of regardless of where they are in their life. And so starting first with fatigue. So I'll talk first about fatigue and then I'll go into the chemobrain. So fatigue is common. And if you talk to people with cancer-related fatigue, they'll explain it. It's like it's a tiredness you've never, ever, ever felt otherwise. You wake up and you're still tired. Like no amount of sleep will change how you feel. And so it really can have this really strong effect on their lives. And again, that the data that really started all of this is that, that cross-sectional study showing the 158 people with breast cancer with IgG, positive CMV IgG prior to treatment had this greater fatigue. And so that is the data that we use to focus on here. And the grant data that we have, I'm actually not presenting because it's a much larger data set that's still accruing, but I'm showing you some pilot data. So this is this small group of 18 people. Blue, so just remember this, blue will be the CMV positive for all these graphs. So blue is CMV positive, orange is CMV negative, again, base DNA, so active viral infection. Here, a higher fatigue score means more fatigue, so higher is bad. You don't really see, these aren't statistically significant. It's slightly higher. I don't know, I'm not convinced after these data. But again, it's only 18 people. We also have a cohort of survivors. So these are people who had ovarian cancer on average about 2 years ago, 160 of them. They're very exactly what I would expect an ovarian cancer cohort to look like. They're 65 years old, 2 years from diagnosis, mostly white, mostly college educated, pretty high incomes, advanced stage disease, and almost half of them had a recurrence prior to participating in this study. So really a very typical Minnesota ovarian cancer group. And again here, so in the survivorship stage, 36% of them had active CMV infection. Okay, so we have kind of this consistent, this consistency that we're seeing. And the fatigue is higher. Again, this is not statistically significant, but is kind of in alignment with what we've seen. And I will say, I think here, something Heather and I have talked a lot about is that fatigue is associated with a lot of different things, right? And so here, I think part of it is that this is a harder symptom to tease apart from other things, whether they're on active treatment, how old they are, all of these confounding things. And so I'm not particularly surprised that fatigue is not this massive difference, because there's so many things that contribute to it. So I would say the jury is out a little bit for us on whether CMV infection is associated with fatigue, and we need this ongoing study that we have with more samples over time, right? So this cross-sectional look is not as compelling. Okay, so now to switch gears to chemobrain, and this work. So funny enough, actually, my very first grant as a faculty member from the Cancer Center was to look at chemobrain a while ago. And this is just a really hard space to work in. It's really hard to measure, because for most people, it's just like, I just can't think the way I could think before, right? And that is hard to measure. We don't have pre-cancer measures of that. And so I used to get a lot of pushback when I tried to write grants in this space, like, well, you can't measure this, you don't have these good objective measures. You need to do MRIs of everybody, all of this stuff. And I'm like, no, but when you talk to patients, they know. Like, I know that the self-reported matters. But thankfully, in the last few years, one, COVID, which I'll explain in a second, but two, there was somebody who took the time to do MRIs and self-reported data on individuals, and actually some objective neuropsych testing, and self-reported data was most aligned with the MRIs and actual changes in white matter. So the self-reported was actually better than the objective for getting at those differences. So, again, trust people, they know, right? So that helped me now to revisit this space. In addition, all of the, and we've seen with COVID, if you pour a whole bunch of money into something, we learn a lot, right? And so we learned quite a bit about, what they're calling long haul brain fog in COVID. They actually realized has a lot of similarities with chemobrain. And so that's been really great, because it's reinvigorating this space and giving us a whole bunch of other ideas and ways to think about this. And so for Heather and I, it was like, whoa, ding, 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 that's a virus. Right? So now I had all these data that I hadn't looked at. What about CMV and chemobrain? And so, that again, just kind of, just be on the lookout for when things kind of push you in a different direction. So it was, this is work that Heather did with a postdoc, maybe pre-doc, somebody. So they looked at CMV and cognitive impairment in cancer survivors, and saw that, again, IgG, so history, history of CMV and high inflammation, they saw greater cognitive impairment in cancer survivors, but it wasn't just CMV alone. But again, this is IgG. So, okay, I have this tiny data set, but I have over time, and these data, I still am struck by these data. This is 18 people. This is active CMV, blue CMV positive, orange CMV negative. Here, higher score is better, right? So a negative difference means you're doing way worse. So these are changes from baseline. These are significant with 18 people. Significant differences in their perceived cognitive impairment if they were CMV positive at diagnosis. And it's consistent, so mid chemotherapy, post chemotherapy, it's pretty standard to see curves like this where as you get further from treatment, you tend to go back to some semblance of normal. Not everybody does, but many do. And then we can measure cognitive functioning in a whole bunch of different ways when you ask people self-report. So, this is a subscale of like, have other people around you said something about your cognitive functioning? Have other people told you you're not remembering things like you used to? And here again, you see the CMV positive group at baseline reported more of these symptoms. And then finally, just even their perceived cognitive abilities too, the same thing. You see this consistent, somehow statistically significant difference in this tiny group. So really suggesting that this is a pretty big effect if we can see this in this group. And again, this is 18 people. We certainly are replicating that, but in all of the things that we have been learning, this is compelling, right? And then we looked at the same thing in the survivor study. So again, these are survivors. About a third of them are currently on treatment. Many of them are not. You see the same. So again, higher is better. So the CMV positive group has lower cognitive functioning. But here, this is, maybe not as compelling of an effect. But if you look at people who are on treatment, so here the left is no chemotherapy in the last 30 days, the right chemotherapy in the last 30 days, that's where you really see this difference, which is in alignment with the pilot study of all of those women were on chemotherapy. So here again, there's something here about being on treatment and having CMV related to cognitive functioning. So again, we have a lot more questions than answers, but we're kind of building this story, right? So what role does inflammation play in this? That's the next question that I don't have answers to, but I have a grant to try to answer. Because really what we want to understand is, so if we buy the idea that CMV is associated with chemobrain, how much of that is mediated through inflammation? So how much of that is explained by inflammation? That's really the goal of this grant. This is a very epi way of talking about it and thinking about it, but just like how much of it is through inflammation versus some other mechanism. And so our plan is to use data that we're collecting both here and from Moffitt, where we have samples from before chemo, after completing frontline chemo, 6 months later, with the associated survey data, which is what's the hard part to find. We're going to look at CMV and EBV. I haven't shown you the EBV data, but what we have found is consistent with what was reported in the breast cancer, that CMV is doing something and EBV isn't. So there is, I would say early on when we did this, we just thought that CMV was just a marker, right? Like this is just a biomarker of maybe inflammation or a biomarker of your immune system function. That doesn't quite seem to be the case. There seems to be something special about CMV. And so we're going to be measuring that inflammation. So stay tuned for those results. But that just is, while I'll show you our whole other list of questions, this is at least one that we are working on addressing actively. So the conclusions that we've drawn so far. So one, some people with ovarian cancer undergoing treatment or in survivorship have detectable active infection. And that this active infection at least seems to be associated with outcomes, maybe fatigue, certainly cancer-related cognitive impairment, EBV doesn't seem to be part of the story, but we will continue to explore that. And really, of course, we need much bigger samples with this longitudinal data. And so really that's kind of what we have found so far. I would say every time we look at these data, as I said, we keep coming up with questions. So these are the questions we are thinking about. I hope that you all will help us come up with more ideas and more questions, and ideally say, yes, I want to look at that too. So, one thing we found is that some people are IgG negative, but they're DNA positive. And so, we are in the process of looking at IgM, which would indicate that they're newly, like very newly infected and they haven't built an antibody response yet. So that's probably some of them. And it's not a huge group, it's 15% or so. But what does that mean? And so that's something that we're kind of digging, and we're not the first people to see it. So it has been reported in the literature among people with cancer that we can see this active infection without the antibody response. So that's one piece that we need to figure out. Heather has done a little bit of looking at CMV in ascites, which is the major thing in ovarian cancer, and the tumor. And I would say, again, here there's discordance that doesn't entirely make sense. So if you're CMV negative in your blood, but you're CMV positive in the ascites, what does that mean? I don't know. And then we, another really important thing for us to understand is how does that timing of that infection affect patient-reported outcomes? So we've been focusing on infection at diagnosis, right? So in most of the work that I've showed you in outcomes, but actually, I also showed you that they reactivate, right? So what happens if I look at viral infection halfway through chemotherapy, and that's that combination of new infection and reactivation? How does that associate with outcomes? And so there's all these questions that we have. And I think most important to us is that, what data do we need to make us feel confident that we can intervene? Because we can, right? So we have antivirals that work for CMV. So, at what data do we need to show us that, okay, when, for how long, for who can we give antivirals and maybe prevent or reduce some of these long-term, really horrible experiences that people have, right? So this, again, this is what makes me excited, right? Like, actually, can we actually help patients? And so, but again, this is where, we're at A and we need to get to Z before we can do this, but really keeps us kind of focused. And there's a CMV vaccination in phase 3 trial right now. And so how will that change the landscape? Could we use vaccination in this group? It would be a catch up because the plan for these vaccinations is in primarily women of childbearing age, because CMV can have really terrible effects on newborn babies. But how is that going to change this landscape as well? So really, again, we have all these questions, but I think hopefully I've convinced you that it's at least an interesting story. And so with that, I'll say thank you, the very wonderful research team that I have, all the research participants. MNCCTN has been fantastic, and they recruited quite a few patients for us, and then certainly funding from all these agencies. And so thank you. I'm happy to take questions.
I have microphones for anyone with a question. Thank you. I really appreciated your talk. I have a question about the reactivation. I understand that it's a herpes virus, so once you have exposure, it's supposed to be latent in your body. But are there different strains that you could get an additional infection with? So reactivation, the measure of reactivation, how do you know it's reactivation versus a new infection?
That's an excellent question. I'm going to let Heather answer. Okay. So the question was, we know it's a herpes virus and that multiple types. And so how do we know we're measuring what we think we're measuring?
Right. How do you know it's the same virus, the same latent virus versus a new one? Especially since you're undergoing chemotherapy and you're going to be immune compromised.
Mm-hmm.
So, thank you.
I'll let you answer. Okay.
Yes, I love that question, and we've tried to look at it. So most people are infected with more than one strain. And we've done some work trying to sequence strains. The viral loads are low enough. It has not been a very successful endeavor, and we have abandoned. I think it's highly likely that these patients are having a mix of new infections and old infections, actually. So, we're measuring IgG as well, which I think is a not good measure. A lot of people actually are infected and don't have an IgG response. Not a lot, but enough that it'll make it messy. And we're also looking at IgM, which will tell us about new infections in the absence of old infection, right? Yeah. Good question though, because one of the driving questions is, all right, is it a particular CMV strain that matters? But because I'm thinking both about etiology as well as outcomes. There's not good evidence for that to date, but it's really hard to tease out. Thank you for the question.
Great talk, Rachel. Thank you so much. I suppose I've almost a few layers of a question. So how long does it go from IgM to IgG? And then when you're CMV or CRV positive CMV, how is inflammation measured? And then finally, sorry, you mentioned that you would like to give antivirals. However, one of your initial graphs showed that the CMV positive but inflammation negative cohort, that red line, was looked pretty significantly better. So would it be not more conducive to increase patient survivorship to find ways to reduce inflammation but keep that CMV status?
Yeah. Potentially, right? I mean Dr. Geller's work hopefully help with some of that. So, I guess the first question about IgM and IgG it's about a 2-week span, is my understanding.
It may be more, and I think we don't know in cancer patients, and we will know because we've got all the time points and we're measuring it.
And then your question, I'm trying. Inflammation, we're measuring. Historically we CRP. But here we're doing the O-link inflammation panel to try to understand, so there's actual, I won't remember the name, but there's some specific markers in COVID and long haul chemo brain that's not CRP, but other inflammation markers that have been shown to have that link. And so we will be looking at those in addition to, the other 90 on the panel.
Awesome. Thanks so much.
Hi, really nice. Really, really interesting and important work. So CMV versus HPV, I know that's also a very, very common virus. Do you guys dissociate between those and then, so we've done some work with Laura Morrow that suggests that viral proteins, when expressed, that disrupt a complex known as DREAM, could synergize with progesterone to drive growth and drive migration and invasion and all these things with ovarian cancer, especially serous. So do you know if your women are on HRT or not, hormone replacement therapy? Because that might be a really big factor if they're taking a whole bunch of hormones.
Most of them would not, it's not likely that they would be, but I don't know that for sure. I know they're
65. I mean,
right
at the time of diagnosis or something is
yeah,
that would be really interesting to see if your group who don't do well are hormone supplemented. It might be easy to figure that out, right?
Yeah.
Or is that a question in the questionnaires, or how do you do that with population data? Do you ever know that?
We have access to all their medical records. That's the benefit of going through Fairview. So we could definitely go back and look. I was actually Heather and I were just talking about the chemo brain data is also really affected by hormones as well, right? And so that there's that whole complexity, especially if of the younger women that you just pushed into menopause instantly. Right. So the hormones have to be part of this conversation. And then, again, 10 more questions on top of, but I agree with hormones are probably part of this conversation.
You just can't do it all, right? So
right.
Thank you.
But you can. No, I'm just kidding.
I have a question from our online from Ann Blaze. It says, thanks for the talk, Rachel. How can you distinguish between this being actually from CMV, or is this just a sign of?
Or I think that that is, part of what we have to tease out. So Melissa Geller is actually using some of our samples right now and doing some CyTOF work. So, again, is it inflammation? Is it immune function? Is it hormones? It's probably all of that. And then the question really is, is CMV a marker, or is it driving all of that? And if it's driving all of that, then, we can do something. And so, I think, Anne, you're totally right. We have a lot of work to do.
Is a part of your future work or future data looking at differentiating between your different ovarian cancer types? They are quite different when you look at them.
Yeah, what we have done historically, because the numbers are so low, is that whenever we look at something in the full group, we look at the subgroup of serous, high-grade serous, right? Because that's 75%, but at least that's a more homogeneous group. And the results have been consistent. But it's a little messier, right? Because those cancers are different. So yes, it's in my brain.
Hi, Rachel. Thank you for the talk. Maybe it's beyond the scope of this talk, but I was just wondering whether CMV reactivation is associated with, say, some survival endpoint, like relapse-free survival, or maybe quality of life adjusted survival, something like that.
I
In the
haven't looked
literature.
at, that's a good idea. Quality. So, quality adjusted life years. Survival, yes. I know we looked at PFS, and I think it's the same, we call it progression. I mean, it's basically recurrence-free survival in this space. The results were similar, not statistically significant, as you have, but close. It's similar. And in this space, overall survival is primarily related to recurrence. So yes to that, but we haven't looked, in those data sets where we have that they're long, we have the survival, we don't have the patient-reported outcomes. So, that as we generate more of the patient-reported outcome data and then have long enough follow-up for survival, we could look at that. That's a great idea, though, because that's what we're on the hunt for, existing data sets that magically have blood and survey data. And if they've been followed long enough, then we could look at that, which I think is a really great question.
Are there any other questions? All right, let's thank Rachel one more time for a great talk. Thank you.
Thank you all very much.